Okay, let's unpack this. Navigating health information can feel like, well, trying to drink from a fire hose sometimes.
Mm.
Every year there's new stats, new research, updated guidelines. It's uh it's easy to feel overwhelmed, wondering what's really important to know.
It is. That feeling of information overload is very real.
Yeah, and we hear a lot about some common cancers, but others, like bladder cancer, are incredibly significant diagnoses here in the US, but maybe don't always get the same spotlight.
And for a topic like cancer, where getting the details right is just so crucial for patients, for practitioners,
Yeah.
cutting through that noise, finding the core knowledge, that's essential.
Right. Getting past the surface.
Exactly. To grasp the fundamentals and, importantly, where things are changing fast.
Absolutely. And that's precisely our mission today on the deep dive. We're going to cut through the noise by going straight to the source.
Hmm.
Our source material for this deep dive is a section from a pretty comprehensive medical text on oncology and hematology specifically. We're diving deep into chapter 86. It's all about cancer of the bladder and urinary tract.
Right. And this chapter gives that detailed, professional level overview, from the basic biology all the way to the very latest treatments.
So our goal here is to unpack this dense info together, pinpoint the key concepts, pull out the most important insights you'd find in these pages.
Exactly. We want to guide you through this complex topic, sort of like how professionals in the field really approach and master this kind of material.
Yeah. I'm actually really excited to dig into the specifics here because the source mentions these rapidly evolving standards of care, especially since, 2016?
That's right.
That pace of change, driven by new understanding, that's where it gets really interesting, I think.
It really does. It underscores why a deep dive like this is so vital right now.
And it highlights the impact of that accelerated understanding, doesn't it? Especially in molecular biology.
Absolutely. That understanding has directly fueled, significant clinical trials, multiple new FDA approvals just in the last few years. It's quite remarkable.
Okay, all right, let's jump right into this chapter then and set the scene. When we talk about urinary tract cancers, what's the broad scope? What parts of the body are we actually including here?
So, broadly speaking, we're talking about cancers that start in the lining of the urinary tract.
Mhm.
That includes the bladder, which is the most common spot, definitely,
Okay.
but also the renal pelvis. That's the part of the kidney that collects urine before it goes into the ureter.
Right.
Then the ureters themselves, those tubes connecting kidneys to the bladder, and finally the urethra, the tube carrying urine out.
And collectively, how big a deal are these cancers in the sort of bigger picture of urological cancers?
Well, the source points out that together, they're the second most common class of genitourinary cancers.
Second most common. So after prostate in men, or maybe kidney cancer overall, these are next.
That's right, they're the next major group diagnosed.
And you said bladder cancer is the most common within this group? Let's focus there for a second. Can we put some numbers on that based on the source? How prevalent is it in the U.S.?
Right. Bladder cancer really stands out. It's the sixth most common cancer diagnosis annually in the United States.
Sixth. Wow.
Yeah. And the chapter gives specific U.S. numbers, roughly 81,400 new cases diagnosed each year.
Over 81,000.
And sadly, around 17,980 deaths annually from bladder cancer.
Sixth most common, over 81,000 cases. That's a pretty substantial impact for just one cancer type.
It really is.
What about the others then? The renal pelvis, ureter, urethra. How much do they add to the overall picture?
Yeah, the source notes that getting precise numbers just for those non-bladder sites is a bit harder, statistically speaking. Cancers of the renal pelvis often get lumped in with other kidney cancers in some databases, but it does give an estimate, maybe an additional 20,000 new cases and about 5,000 deaths each year attributed to cancers of the renal pelvis, ureter, and urethra combined.
So less frequent than bladder cancer individually, but still significant number.
Definitely. Still a significant burden.
Okay, so if we put it all together, we're looking at, over 100,000 new diagnoses and maybe over 22,000 deaths from all urinary tract cancers combined each year in the U.S.
Roughly, yes. That's the scale we're talking about. It clearly establishes their importance.
And you mentioned that rapid pace of change earlier. What's driving that, according to the source?
The source is really explicit here. It says an accelerated understanding of the molecular biology, the fundamental genetic, the cellular stuff, underpinning these cancers. That's been the main driver of recent progress.
And this biological insight, it hasn't just stayed in the lab.
Not at all. It's directly led to a big increase in clinical trials testing new therapies.
And those trials have actually produced results.
Absolutely. The chapter highlights that this wave of research has resulted in multiple new therapeutic agents getting FDA approval since 2016.
Multiple approvals in just, what, the last 8 years or so?
Exactly. That's a fast pace in oncology.
Wow.
And the source anticipates more novel therapies are likely to follow as this understanding keeps growing.
So this is a really dynamic field right now.
It is. That rapid evolution is why understanding the details in this chapter is so critical, because the standard of care is actively being redefined as we speak.
That's where it gets really interesting, seeing that science translate so quickly.
It shows the power of digging into that basic biology.
It really does. Okay, let's shift gears then. From the overall picture to who typically gets these cancers and why, what does the source tell us about the clinical epidemiology and the risk factors?
The source paints a pretty clear demographic picture for bladder cancer. It most commonly affects older individuals. The median age at diagnosis is 73.
73. So primarily a disease of older age. And there's a really big difference between men and women, isn't there?
Yes, a very striking one. Males are affected 4 times more frequently than females.
4 times. Wow.
Yeah. And the source also notes a racial disparity. It's more common in Caucasians compared to Asian patients. So the typical profile leans towards older Caucasian men.
Okay, so age, sex, race. What about genetics? Is this something that can, run in families? Is it inherited?
The source says, yes, inheritable germline genetic risk factors have been identified, and they're present in a non-trivial number of patients. Up to 1/7 of people diagnosed with bladder or upper tract cancer might have one.
1 in 7. That feels higher than you might think. Are there specific genetic syndromes mentioned?
Yes, several key ones. Lynch syndrome is particularly important, especially for those upper urinary tract cancers, the renal, pelvis, and ureter.
Okay.
This syndrome is caused by inherited defects in DNA mismatch repair genes, things like MLH1, MSH2, MSH6.
So the genes that normally fix DNA errors aren't working right?
Exactly. That leads to more DNA mutations building up, including in the urinary tract lining, increasing cancer risk.
Makes sense. Any others mentioned?
The source also mentions links with Cowden disease, involving PTN gene mutations and retinoblastoma linked to RB1 mutations. People with these syndromes also seem to have a higher susceptibility to bladder cancer.
What's interesting, though, the source points out that even with these known genetic links, the exact impact on the family member's risk, that's still uncertain.
That's a key nuance, yeah. It means we know the link is there for the person with the syndrome, but how much it increases the risk specifically for urothelial cancer in their relatives.
Yeah.
That's not fully clear yet. Needs more research.
So important for the patient, but maybe less predictive for the rest of the family for this specific cancer right now.
That seems to be the takeaway from the source, yes.
Okay. Beyond those fixed factors like age and genetics, the source talks a lot about environmental and lifestyle risks. And some of these have really strong historical links, right?
Absolutely. Exposure to certain chemicals, especially in industrial settings, has been linked to bladder cancer for a long time.
Like what specifically?
The source calls out aromatic amines, things like benzidine and beta-neophylamine, which were used in industrial dyes. Also, arsenic exposure, particularly from contaminated drinking water in some underdeveloped countries, that's another well-established major risk factor.
Okay, so specific chemical exposures. What other industries or chemicals come up?
Well, it lists chemicals used in leather, paint, rubber, textiles, and printing industries as having suggested associations. And interestingly, there are even suggested links with exposures for hairstyling workers, things like hair dyes and sprays.
That broadens it out quite a bit. What about medications? Is there any drug link mentioned?
Yes, the source discusses the anti-diabetic medication pioglitazone. There's been some back and forth on this, concern about a potential link to bladder cancer risk.
Okay.
The source notes that while different studies, meta-analyses have reached somewhat different conclusions, the overall data does suggest a small increased risk of bladder cancer with long-term use.
A small risk, but enough to be noted.
Enough to be reflected in the drug's official prescribing information, yes.
Got it. And what about chronic inflammation? Does that play a role?
Yes. The source clearly links chronic inflammatory states to the development of squamous cell bladder cancer. That's a less common type, but significant.
And what are the main examples of that kind of chronic inflammation?
It gives 2 key ones. Globally, chronic infection with the parasite that causes schistosomiasis, that's common in certain underdeveloped countries and is a clear driver.
Okay.
And then in developed countries, chronic irritation from long-term indwelling urinary catheters. You see those often in patients with spinal cord injuries, for example. That constant irritation is also linked to a higher risk of squamous bladder cancer.
So that persistent irritation or infection can change the bladder lining over time, but the source seems really emphatic that while all these factors play a role, one factor just dwarfs the others.
Yes, it's incredibly clear on this, it says, and I'm basically quoting here. Above and beyond each of these associations, however, smoking of tobacco products, cigarettes, cigars, pipes, etc., remains the overwhelming leading risk factor for development of bladder cancer.
The overwhelming leading risk factor.
Okay.
Quite a statement.
It is. And the stats provided are just stark. The source estimates that among new bladder cancer cases diagnosed each year, a staggering 90% occur in people who are current or former smokers.
90%. 9 out of 10 new diagnoses linked to tobacco.
That's what the source indicates. And toxicological studies, they've found over 70 confirmed carcinogenic toxins just within tobacco smoke.
70?
70 confirmed carcinogens, and many of those are known to be excreted in urine, which means they're bathing the bladder lining directly.
Wow. Okay, when you hear that and the 90% statistic, it raises a massive question for public health, doesn't it? If smoking is that dominant, what's the potential for prevention here?
The source gives a pretty striking estimate for that, too. It suggests that as many as 1/3, maybe 33% of all bladder cancer cases could potentially be prevented just through lifestyle changes, especially quitting smoking.
1/3 preventable just by tackling smoking. That has to be one of the biggest takeaways from this whole section.
It really is. It's not just a risk factor. It's a massive, potentially modifiable one.
It really highlights where prevention efforts could make the biggest difference.
Exactly. So if you synthesize this section, you have the age, sex, race factors, some genetic links, various environmental or inflammatory causes, but fundamentally, it's the dominant, overwhelming, and highly preventable role of tobacco smoking that stands out.
Okay, so we know who tends to get it and the major risks, especially smoking. Now, how does this cancer usually show up? What are the typical signs or symptoms that bring someone to the doctor? And what's the initial workup look like?
The source is very clear. The most common initial sign is painless hematuria.
Blood in the urine, but no pain.
Exactly. It can be visible blood, what they call gross hematuria, or it might only be picked up under a microscope during the urine test, microscopic hematuria.
And the painless part is key, you're saying?
It really is, because painful urination or blood with pain often points to more common things, like a urinary tract infection, UTI, or maybe kidney stones. Painless blood, especially if it's visible, is a much stronger red flag for something more serious, like cancer.
Does it present differently in men versus women?
Well, the source notes a challenge, particularly for women. Hematuria from bladder cancer can sometimes be mistaken initially for a UTI or even related to menstrual bleeding.
Ah, so a potential for delay in diagnosis there.
Unfortunately, yes. The source really emphasizes that while treating a suspected UTI is right, if the hematuria persists after that treatment, you absolutely need further investigation for other causes, including cancer. Don't just assume it was only a UTI if the blood doesn't clear up.
That's a critical point. Don't ignore persistent symptoms.
Exactly. And for men, the source is even more direct. It says painless hematuria in males is, quote, almost always abnormal and absolutely needs a thorough workup.
Almost always abnormal. That really drives home the need to investigate in men. Are there less common ways it might present?
Less commonly, patients might present with flank pain. That could happen if there's a tumor higher up in the renal pelvis or ureter, or maybe if a bladder tumor is blocking the ureter where it enters the bladder, causing urine to back up into the kidney. That's called hydronephrosis, and it can be painful.
Okay.
But the source also notes it's pretty rare for patients to show up initially with really advanced symptoms like significant weight loss, that muscle wasting called cachexia, and widespread metastatic disease. Usually the local symptoms from the tumor itself appear first.
Right, so painless blood in the urine is the main thing to watch for. Once that happens, what are the standard first steps in the diagnostic workup, according to the chapter?
The standard initial investigations are a urine cytology test and then a visual exam of the bladder using a scope that's called cystoscopy.
Urine cytology that's looking for abnormal cells shed from the bladder lining.
Correct. But the source points out a pretty significant limitation. Cytology only successfully picks up cancer cells in about half, maybe 50%, of people who actually have high-grade bladder cancers.
Only 50% for high grade. So it's not a perfect test.
Definitely not perfect. Useful, but it can miss things, especially the more aggressive tumors.
And cystoscopy lets the doctor look directly inside the bladder.
Exactly. They can see any visible tumors or abnormal patches. In addition to those, imaging radiographic evaluation of the kidneys and the upper urinary tract is also really crucial because cancer can pop up anywhere along that tract.
What kind of imaging is typically used for that?
The source says CT urogram is currently the preferred method for imaging the upper tract. It's largely replaced older techniques like intravenous pyelograms or IVPs.
And why is CT urogram better now?
Well, it offers increased sensitivity. It's better at detecting tumors or abnormalities throughout the whole urinary tract, and it usually requires less intravenous contrast dye compared to the older IVP.
Okay.
The source also mentions that if a patient has poor kidney function and can't handle the CT contrast well, then an MR urogram using magnetic resonance imaging can be a substitute.
So we've got urine tests looking inside with a scope and imaging. The source also mentions some other, maybe more advanced urine-based tests. What's their role right now?
Yeah, these are often called adjunct molecular or cellular tests. Examples include things like FIS, that's fluorescent in situ hybridization, looking for specific chromosome changes in shed cells, or tests for nuclear mitotic proteins, or bladder tumor antigens, or assays that detect higher staining levels on shed cells.
Do these newer tests catch cancers that the standard cytology misses?
They can identify some missed cancers, yes, but the source also warns they can sometimes give abnormal results even when someone doesn't have cancer, so false positives.
Okay.
According to the chapter, their main use right now isn't really for the initial diagnosis. It's primarily used for detecting recurrent cancer in patients who've already been diagnosed and treated previously.
That's a key difference in how they're used in practice. So if any abnormality is seen on imaging or during cystoscopy, what's the absolutely essential next step?
The source really emphasizes this. Complete endoscopic resection of any visible abnormality is critical, both for getting a tissue diagnosis and for staging, whenever it's technically possible.
This is the TURBT procedure for bladder tumors we hear about.
Exactly. Transurethral resection of bladder tumor, or TURBT for bladder lesions. If it's a suspected tumor up in the ureter or renal pelvis, it'd be an endoscopic resection there.
And the goal is twofold.
Yes. First, get tissue to look at under the microscope, confirm if it's cancer, what type it is. Second, determine how deeply it's invaded into the wall, which is absolutely crucial for staging the disease.
So that endoscopic resection isn't just for diagnosis, it's often the first treatment step for less invasive tumors, and it gives you the info you need for all the next decisions.
Precisely. It's really the cornerstone procedure for diagnosis and the initial management of any visible tumors.
Which leads us nicely into histology, what these cancers actually look like under the microscope. What's the main type the source describes?
The vast majority, like 90% of all bladder and urinary tract cancers, are classified as urothelial carcinoma.
Urothelial carcinoma. That used to be called transitional cell carcinoma, right?
That's right, yeah, reflecting the type of cells lining the tract. But urothelial carcinoma is the current term.
Does it always look the same under the microscope?
Not necessarily. The source notes that while the main component is urothelial carcinoma, these tumors often contain what are called variant features.
Variant features, like what?
These are areas within the tumor that might look like other cancer types, maybe squamous cell carcinoma or adenocarcinoma.
Yeah.
Or they might have specific growth patterns like micropapillary, plasmacytoid, or sarcomatoid features.
But the source says that pure variant types where the whole tumor is, say, squamous or adenocarcinoma with no urothelial part, those are pretty rare.
Yes, that's correct.
Yeah.
Pure squamous cell, adenocarcinoma, small cell carcinoma, or carcinosarcoma. Together, they make up a much smaller slice, probably less than 10% of all urinary tract tumors.
Why is it important for the pathologist to spot these variant features or note if it's a pure variant? Does it matter?
It really does matter. The source highlights that having some of these specific variant histologies, particularly micropapillary and plasmacytoid variants, seems to be associated with worse surgical outcomes compared to tumors that are just pure urothelial carcinoma without those features.
Worse outcomes. So finding those variants might mean a tougher prognosis.
It can, yeah. Knowing they're present can influence the prognosis and might push towards more aggressive treatment strategies earlier on. The source actually points to figure 86.1, which visually shows the different looks of urothelial carcinoma and some variants under the microscope, just emphasizing how distinct they can be.
Okay, so the microscopic details really count, not just for naming the cancer, but maybe predicting its behavior. And this connects directly to understanding the molecular biology, the genetic blueprint driving these looks and behaviors.
Yes, the source goes right into the molecular biology, and it introduces a really fundamental concept for bladder urothelial carcinoma. It seems to have a biphasic phenotype.
Biphasic, meaning like two main different ways it grows and behaves.
Exactly. On one side, you've got low-grade papillary tumors. These tend to grow outward like little fingers into the bladder space. They come back frequently. Recurrence is common after removal.
Okay.
But the key thing is they rarely invade deep into the bladder wall muscle layer or spread to distant sites.
So annoying because they recur, but generally less dangerous. What's driving those?
The source says these are typically linked to changes in the ASWAF signaling pathway. Specifically, activating mutations or gene fusions in the FGFR3 gene are really characteristic. Found in a big chunk of these tumors, maybe 60 to 80% of cases.
Okay, FGFR3 alterations a signature for these less aggressive, non-invasive types. What's the other side of the coin then, the other phenotype?
The other side is the high-grade invasive tumors. These can sometimes grow flat, like CIS or as papillary tumors, but their defining feature is they tend to invade early and deep into the bladder wall muscle.
And that invasion is what makes them so dangerous.
Precisely. That's what can lead to lethal metastatic disease if they're not caught and treated effectively.
These are the more aggressive ones. What molecular changes are driving this kind of behavior?
These high-grade invasive types are characterized by early, often harmful mutations in key tumor suppressor genes, particularly TP53 and RB1.
Tumor suppressors, the genes that normally put the brakes on cell growth.
Exactly. When they're mutated and broken, cells can grow out of control. These tumors also often show changes in CDH1, which makes EC-adherent a protein that helps cells stick together, and increased expression of VEGFR2, which helps tumors build blood vessels to grow and spread.
So completely different genetic pathways seem to be driving these two very different clinical behaviors. Is there anything molecular that happens early in both types?
Yes, the source mentions that losing parts of chromosomes 9q and 9p through something called loss of heterozygosity seems to be an early event seen in both the low-grade papillary and the high-grade invasive pathways.
Huh.
The exact meaning isn't totally clear, but candidate genes in those regions include things like CDNK2A and TSC1.
So an early genetic hit might be shared, but then the path splits dramatically. Now, we mentioned Lynch syndrome earlier under risk factors. How does that tie back into this molecular picture, especially for upper tract cancers?
Right, the source reinforces that connection. It states that a significant chunk, maybe 10 to 20% of urothelial cancers happening up in the renal pelvis and ureter are linked to Lynch syndrome.
And that's those mismatch repair gene defects again.
Yes, defects in MLH1, MSH2, or MSH6 leading to this thing called microsatellite instability and just a lot more DNA mutations accumulating in the tumor cells.
So testing for those specific inherited mutations is recommended if Lynch syndrome is suspected.
Yes, the source actually gives criteria for when germline testing is recommended. If someone's diagnosed with upper tract urothelial cancer under age 60, or if they have a close relative diagnosed with a Lynch-associated cancer under 50, or if they have two close relatives diagnosed at any age.
Okay, that's pretty specific guidance.
Yeah, it helps identify patients and families who could benefit from genetic counseling, maybe different screening for other Lynch-related cancers.
That's very practical.
Wow.
The source also talks about how these large-scale genomic analysis technologies have just fundamentally changed our understanding of bladder cancer's molecular landscape. The Cancer Genome Atlas project sounds like it was a huge deal here.
It really was. The source highlights the big results published back in 2017 from the Cancer Genome Atlas, or TCGA, project specifically for bladder cancer.
What did they do in that project?
It was this massive collaborative effort. They did incredibly deep analysis on tumor samples from patients who had had surgery, looked at everything specific, gene mutations, fusions, how active genes were, expression, changes in chromosome numbers, DNA methylation patterns, even microRNAs, just layers upon layers of molecular data.
Wow. Looking at the tumor's blueprint from every angle, what were the biggest takeaways from that huge project, according to the source?
Several really critical findings came out that are still shaping how we think. First, they found that a large majority of bladder cancer, 71% in their analysis, had genomic alterations in genes that are potentially targetable by drugs we already have or that are in development.
71% with potentially targetable changes. That sounds really promising for personalized therapy.
It is huge. It gives us a roadmap, potentially. Genes like FGFR3, we talked about that. EGFR, ERBB2, also known as HAR2, ERBB3, PIK3CA, TSC1, a whole list of potential targets.
What else did they find?
Another key finding was that alterations in genes that code for chromatin modifiers, these are proteins that help control how DNA is packaged and read, were found in most patients. genes like KMT2D, KDM6A, KMT2C. They also found epigenetic silencing through hypermethylation in about a quarter of patients.
And the source mentioned something about molecular subtypes identified through RNA sequencing.
Yes, this was arguably one of the most impactful findings. By looking at RNA expression, basically, which genes were turned on or off, TCGA identified 5 distinct intrinsic molecular subtypes of bladder cancer.
5 distinct types.
Yeah, they labeled them luminal papillary, luminal infiltrated, luminal basal squamous, and neuronal. And the source points out these subtypes look a lot like the known luminal and basal subtypes we see in breast cancer.
Suggesting maybe similar underlying biology and behavior?
Potentially, yes. It really changes how we classify bladder cancer, moving beyond just how it looks under the microscope to include this underlying molecular diversity.
So just like breast cancer isn't one single disease, TCGA showed bladder cancer isn't either at the molecular level.
Precisely. It's a fundamental shift.
What are the future implications of all these incredibly detailed TCGA findings then?
The source says these findings are giving us invaluable new insights. They're helping refine classification, improve prognosis prediction, understand treatment resistance better, and critically, helping identify candidate biomarkers.
Biomarkers like molecular flags in the tumor.
Exactly. Flags that could potentially predict which patients are most likely to respond to which specific therapies.
This is where it gets really exciting. This molecular understanding isn't just academic. It's directly feeding into that quest for personalized medicine, trying to match the right treatment to the right patient based on their tumor's unique profile.
It moves us closer to that future, yeah. Where a tumor's molecular profile might help guide treatment choices, not just the clinical or histological factors alone.
Which brings us naturally to staging. Because ultimately, even with all the molecular insights, the anatomical spread of the cancer at stage is still absolutely critical for prognosis and treatment strategy. What does the source tell us about how bladder cancer is staged and how stage relates to outcomes?
Right, staging for bladder cancer uses the standard T&M system. T is for the depth of tumor invasion into the bladder wall, N is for spread to regional lymph nodes, and M is for distant metastasis.
Right.
The source references figure 86.2, which visually shows the layers of the bladder wall and the lymph nodes in the pelvis that are important for staging.
Let's break down the T staging first, because that seems particularly key in bladder cancer.
It is. The source says the initial presentation for most patients, maybe 75%, is what's called non-muscle invasive bladder cancer, or NMIBC.
NMIBC, what does that include?
That includes tumors just in the innermost lining, TES, which is carcinoma in situ, a flat high-grade lesion, and TES, which are non-invasive papillary tumors.
Yeah.
It also includes T1 tumors, which have started to penetrate into the connective tissue layer just beneath the lining, the lamina propria.
But the key is they haven't hit the muscle.
Exactly. The defining feature of NMIBC is the tumor has not invaded into the main muscle layer of the bladder wall, the muscularis propria.
Okay, so NMIBC is limited to those inner layers.
Right. Then you have muscle-invasive bladder cancer, or MIBC. That accounts for about 18% of new diagnoses.
And MIBC is when?
MIBC is defined by tumors that have invaded into the muscularis propria, that's T2, or have grown through the muscle into the fatty tissue surrounding the bladder, T3, or have invaded into nearby pelvic organs like the prostate, uterus, vagina, pelvic wall, T4.
So once it hits that muscle layer, T2, or goes beyond, it's officially muscle invasive, a much more serious category.
Definitely. And the source notes only about 3% of patients present right at the beginning with distant metastatic spread, M1 disease. Most are diagnosed when it's still local or regional.
Okay. What about the end staging, the lymph nodes?
End staging focuses on those regional lymph nodes in the pelvis. N1 means cancer in just one node in the true pelvis. N2 means 2 or more nodes in the true pelvis. And 3 means it's spread up to the common iliac nodes, a bit higher up.
And M staging is just distant spread?
Yes. M1 means any distant metastatic disease cancer spread to sites beyond those regional nodes, like liver, lungs, bones, or lymph nodes outside the pelvis.
How do these T, N, and M categories combine to give the overall stage group stage 0, I, 2, 3, Phi?
The source explains that the overall stage is really driven by the T stage for localized disease. Stages 0A, 0I, and 2 are all defined by tumors confined to the bladder wall with no nodes and no distant spread, N0M0.
So stage 0 is TISTA, stage 1 is T1, stage 2 is T2.
That's right. But here's a key jump. Any involvement of regional lymph nodes, N1, N2, or N3, regardless of the T stage, T1 through T4, automatically makes it stage 3.
Any nodes involved means at least stage 3.
Yes. And of course, any distant metastases, M1, no matter the T or N stage, makes it stage 4.
So regional node spread bumps the stage up significantly, and distant spread puts it in the highest category. What's really striking, and honestly quite sobering, is how directly these stages link to prognosis. The source gives 5-year overall survival rates based on figure 86-2.
They do, and the numbers really show the impact of invasion and spread. For stage 0N0M0, it's just a N0M0, the 5-year overall survival is excellent, 96%.
Great prognosis when caught that early, non-invasively.
For stage I, T1N0M0, where it's just into that connecting tissue layer but not muscle, survival is still very good at 90%.
Still good.
But once it hits the muscle layer, stage 2, T2N0, the 5-year survival rate drops noticeably down to 70%.
Wow, from 90% down to 70% just by hitting the muscle. That really highlights why that muscle layer, the muscularis propria, is such a critical boundary.
It absolutely underscores the biological difference between non-invasive and muscle-invasive disease. Now, for stage 3, this includes T3N0M0 through the muscle, no nodes, or any T stage, T1, T4, with regional node involvement, N1, N3M0. The prognosis worsens again.
How much worse?
Well, based on the table in figure 86-2, T3N0M0 has about a 50% 5-year survival. But if there's regional node involvement, T1, T4, N1, N3M0, it drops further down to 36%.
That's a huge drop, again, from 70% at stage 2 down to potentially 36% if nodes are involved in stage 3. It shows how serious that regional spread is.
And what about stage 4 distant metastases?
For stage 4, any T, any N, M1, where the cancer is spread far beyond the pelvis, the 5-year overall survival rate is only 5%.
5%. That number just hammers home the importance of catching and treating this effectively before it spreads. The prognosis changes so dramatically with metastatic disease. It absolutely reinforces the need to manage localized disease aggressively and effectively to prevent that progression.
And speaking of management, the source then dives into the different treatment approaches, stressing that they really depend heavily on that stage. So let's unpack this section, maybe stage by stage. We'll start with the early stage stuff, the non-muscle invasive bladder cancer, NMIBC we just defined.
Right. So NMBC includes those CIS, TA, and T1 tumors cancers stuck in the inner layers above the muscle. For these stages, the absolute mainstay of surgical treatment is TURBT transurethral resection of bladder tumor.
The procedure we talked about for diagnosis.
Exactly. It serves both for diagnosis and as the primary surgical treatment to physically remove all the visible tumor.
Okay, so after the TURBT, what happens next for NMIBC?
Well, after a complete TURBT, patients are assessed for the risk of the tumor coming back, the risk of recurrence. The source describes stratifying patients into low, intermediate, or high risk based on characteristics laid out in Table 86-1.
Can you give us a quick rundown of what defines those risk groups?
Sure. Low risk is generally an initial, single, small, less than 3 centimeters, low-grade TAT tumor with no CIS anywhere else in the bladder.
Okay, the best case scenario for NMIBC.
Pretty much. High risk is defined by having any T1 tumor, meaning it's invaded the lamina propria, any high-grade histology, even if it's TA, or the presence of carcinoma in situ, CIS. It also includes some specific TAF, low-grade tumors if they're multiple, recurrent, and large, over 3 centimeters. You need all 3 of those for a low-grade TAT to jump to high risk.
Got it. So T1, high-grade, or CIS automatically puts you in the high-risk group. And intermediate risk is everything else in between.
Exactly. All the others not fitting low or high risk fall into intermediate.
And this risk level dictates the next steps.
Yes. Based on this risk stratification, additional treatment after the 2RBT, called intravesical therapy, is often recommended. This means putting liquid medications directly into the bladder.
Okay, like a bladder wash with medicine. What agents are used and for which risk groups?
For patients with low-risk NMIBC, studies show that a single dose of chemotherapy like mitomycin C, epirubicin, or gemcitabine instilled right into the bladder, usually within 24 hours after the TURBT, can reduce the risk of early recurrence by about 12%.
So a quick chemo wash helps for low risk. What about intermediate and high risk? They need something more.
Yes. For intermediate and high-risk NMIBC, the standard approach involves a course of weekly intravesical instillations of DCG.
BCG, that's bacillus-calmette-guerin, the tuberculosis vaccine.
That's the one. It's an attenuated, weakened strain of Mycobacterium bovis. Putting in the bladder triggers a really strong local immune response against the cancer cells. A typical initial course is 1 installation per week for 6 weeks straight.
How effective is BCG for these higher-risk tumors? Does it work well?
It significantly reduces the risk of recurrence compared to just doing the TURBT alone in these intermediate and high-risk patients. The source cites a study where recurrence at 12 months dropped from 56% without BCG down to 29% with BCG.
Wow, that's cutting the recurrence rate almost in half. Does BCG do anything else important?
Yes, and this is critical. The source notes that BCG treatment can also reduce the risk of the cancer progressing to become muscle-invasive bladder cancer, MIBC.
Ah, so it might stop it from getting worse, not just coming back.
Exactly. Preventing that progression is a huge goal, given how much the prognosis drops once it hits the muscle.
Makes sense. What about side effects from putting BCG in your bladder?
Common side effects are mostly local irritation things like painful urination, dysuria, having to go more often, frequency, bladder spasms, maybe some blood in the urine, hematuria.
Okay, local stuff. Anything systemic.
Systemic side effects are rare, less than 5% of patients according to the source. But they can be serious if they happen like a widespread inflammatory response that mimics a disseminated BCG infection. Needs careful monitoring.
Is that initial 6-week course of BCG usually enough?
The source explains that while that induction course is key, studies have shown that getting additional maintenance BCG treatments given periodically over months or even years on specific schedules, like the Southwest Oncology Group schedule, further cuts the risk of recurrence compared to just getting the induction course alone.
So maintenance is generally recommended for high-risk patients.
Generally, yes, for high-risk patients who tolerate it well.
What happens if the NMIBC does come back, even after someone's had BCG?
That's a really critical point.
Yeah.
The source gives some guidance here. If the cancer comes back a long time after finishing BCG, maybe repeating a course of BCG could be considered, especially if the first response was good.
Okay.
However, if the cancer comes back quickly after BCG specifically, if it relapses after getting a second adequate course, or if it recurs within just 6 months of the initial BCG exposure, the risk of it progressing to muscle invasion is considered very high.
So if BCG stops working quickly, that's a bad sign.
It's a sign the cancer might be biologically more aggressive. In those situations, the source states that surgical removal of the entire bladder, radical cystectomy, is the recommended course of action.
Whoa, radical cystectomy, even though it's still technically non-muscle invasive? That sounds like a huge jump.
It does seem like a big jump, but the rationale, according to the source, is clear. The risk of that cancer rapidly becoming muscle invasive or even spreading is just too high to keep trying intravesical therapy alone. Failing BCG in that high-risk setting strongly suggests you need definitive surgery to remove the bladder before things get worse.
Okay, understood. Are there any alternatives if someone just isn't fit for that major surgery or if they refuse it?
Yes, for patients who aren't surgical candidates or decline cystectomy, other intravesical agents can be tried. These include different chemo drugs like mitomycin C, gemcitabine, docetaxel, or valrubicin. They work differently than BCG. The source also mentions that systemically given immune checkpoint inhibitors, the PD-L1 inhibitors like pembrolizumab, have shown some durable responses in a small fraction of patients with this BCG-unresponsive high-risk NMIBC. So that offers a non-surgical systemic option for some.
Interesting. Okay, so that covers the management of NMIBC pretty thoroughly. What happens when the cancer has already invaded the muscle layer? That's muscle-invasive bladder cancer, MIBC.
Right. For MIBC, that's still apparently confined locally or regionally, so T2, 3, maybe T4, but no documented distant spread. The source emphasizes that much more aggressive therapy is needed for any chance of cure compared to NMIBC. The options are summarized in Table 86-2.
And there are some approaches that try to save the bladder, right?
Yes, there are bladder-sparing strategies, but the source is careful to note these are typically for very carefully selected patients. One main approach is combined modality therapy.
Combined modality, what does that involve?
That involves getting both chemotherapy and radiation therapy directed at the bladder concurrently.
Who is a good candidate for this chemoradiation approach?
The source lays out criteria. Ideal candidates are, again, carefully selected. They shouldn't have extensive carcinoma in situ, CIS, no blockage of the ureters causing kidney swelling, hydronephrosis, and this is critical. They must undergo a maximal TURBT first to remove as much visible tumor as possible before starting the chemoradiation.
Okay, so you need a good debulking first. What kind of results can you expect with this bladder-sparing approach in those selected patients?
In those carefully chosen patients, combined chemoradiation can achieve a cure rate of around 65%. And importantly, it allows the bladder to be preserved in about 55% of those patients.
So, pretty good outcomes, but it depends heavily on that selection.
Highly dependent on patient selection and achieving a complete response to the initial treatment, yes.
What kind of chemo is used with the radiation?
Various regimens have been used,
Yeah.
often based on cisplatin, either cisplatin alone or combined with drugs like 5-fluorouracil. Other regimens might use gemcitabine, paclitaxel, or mitomycin C. It depends on the protocol and the patient.
And if someone goes through this, has a complete response, keeps their bladder, what's the follow-up like?
Close monitoring is absolutely essential. Regular cystoscopies, often with biopsies, to check for any recurrence inside the bladder.
And if MIBC does come back after chemoradiation?
Then the source notes that salvage radical cystectomy, removing the bladder at that point, is offered. So bladder preservation is the goal, but surgery is the backup if the cancer returns aggressively.
Got it. Is there any other bladder-sparing option?
The source mentions another surgical option, partial cystectomy.
Partial cystectomy. Just removing part of the bladder. Is that common?
No, the source clarifies this is really only appropriate for a very small subset of MIBC patients. The ideal candidate is someone with a single clinical T2 urothelial carcinoma located specifically in the dome of the bladder.
The dome. Why there specifically?
Because the dome is the top, more mobile part. Tumors there can sometimes be cut out with good margins, and the remaining bladder can be sewn back together, potentially allowing for more normal urinary function compared to removing the whole thing.
And the outcomes with partial cystectomy.
Variable, and again, highly dependent on super careful patient selection and surgical skill for that specific scenario. It's definitely not a standard option for most MIBC.
Okay, so while these bladder-sparing options exist for some, it sounds like for the majority of patients with MIBC, radical surgery is still the main path.
That's correct. Radical cystectomy is required for most patients with muscle-invasive bladder cancer who don't have signs of distant spread.
Let's walk through what that actually involves. What gets removed in men versus women during a radical cystectomy?
In men, the standard procedure is usually a cystoprostatectomy. That means removing the bladder, the prostate gland, and the nearby pelvic lymph nodes.
Okay. Bladder, prostate nodes, and in women.
In women, it's often an anterior exoneration. This typically involves removing the bladder, the uterus, ovaries, cervix, and also the pelvic lymph nodes.
That's a lot removed. So once the bladder is gone, how do they manage urine? Where does it go?
Yeah, that requires urinary diversion surgery. The source describes three main ways urine outflow is rerouted. The first is the ileal conduit, sometimes called an ileostomy. Ileal conduit, how does that work? They take a short piece of the small intestine, the ileum, connect the ureters, the tubes from the kidneys, to it. Then they bring one end of that intestinal segment out through the abdominal wall to create a stoma. Urine flows continuously from the kidneys through that piece of intestine and out the stoma into an external bag the patient wears.
Okay, so continuous drainage into an external bag. What's option 2?
Option 2 is a continent urinary reservoir. You might hear names like Indiana pouch or cock pouch. Here, they use a larger piece of intestine, small or large, to create a pouch or reservoir inside the body. The ureters drain into this pouch.
Stored internally. How does it get out?
They bring a small channel, often made from intestine too, up to the skin surface, creating a small, usually flat stoma with a valve mechanism. The patient inserts a catheter through this stoma into the internal pouch several times a day to empty the urine. So no external bag, but requires self-catheterization.
Okay, internal storage, manual emptying, and the third option.
The third option is a neobladder. Here, they again use a piece of intestine to create a pouch, like a substitute bladder. But this pouch is placed down in the pelvis and surgically connected directly to the patient's remaining urethra.
So connected to the normal exit path.
Exactly. The idea is to allow the patient to potentially void urine through the urethra, trying to restore a more natural way of urinating. Though patients often need to learn specific techniques, like straining, and might still need to catheterize sometimes to make sure they empty completely.
Those are 3 really different ways to handle things after bladder removal. How do they decide which one is best for a particular patient?
The source says the choice depends on a lot of factors. Patient factors like their overall health and functional status, their anatomy after the cancer removal, other medical problems, their own preferences, and also, critically, the experience and comfort level of the urologic surgeon with each technique. It's a very individualized decision.
Sounds like it. What's the recovery like after such a huge surgery like radical cystectomy? And are there long-term impacts?
The source points out it's a major metabolic hit, a significant catabolic stress. Even if patients weren't thin beforehand, it's common to lose 10 to 15 pounds in the first month after surgery just from the stress and recovery.
Wow.
And long-term, there can be nutritional issues. For example, low vitamin B12 levels can happen because the parts of the small intestine often used for the diversion are important for absorbing B12. So that needs monitoring.
That really highlights the systemic impact. Now, even with this massive surgery, the source said only about half of patients are actually cured by the surgery alone.
Yes, that's a really crucial statistic. It implies that even after removing everything you can see, about half of patients likely have microscopic cancer cells that have already escaped the surgical area. These micrometastases will eventually cause recurrence.
And that's why systemic chemotherapy plays such a big role in MIBC.
Exactly. That reality is why systemic chemo is vital.
So where does it fit in? Before surgery or after?
Both ways have been studied. Giving systemic chemo before surgery, that's called neoadjuvant chemotherapy, has shown a clear survival benefit. Meta-analyses show a 5% to 10% absolute improvement in overall survival when you use cisplatin-based combination chemo regimens before the cystectomy compared to just doing surgery alone.
So chemo up front improves the odds of cure. What about giving it after surgery, adjuvant chemo?
A similar benefit seems to exist with giving cisplatin-based chemo after surgery. But the source notes the data supporting adjuvant chemo comes from generally smaller, older trials compared to the neoadjuvant data. Plus, there's a practical issue with adjuvant. Patients need to recover from that massive surgery first, and sometimes they don't bounce back quickly enough to get the chemo within the ideal window for it to be most effective. That makes it harder to reliably give to everyone who might benefit.
So the neoadjuvant approach, giving chemo first when possible, seems maybe preferred due to stronger data and easier timing.
That's generally the implication, yes. And crucially, the source hammers this point home. Chemotherapy regimens that do not contain cisplatin have consistently proven inferior for urothelial cancer.
Cisplatin is really the key drug here.
It absolutely is. And this has a direct clinical consequence. Patients who can't tolerate cisplatin, maybe due to poor kidney function, poor overall health, other major medical issues, they generally should just proceed directly to surgery and skip neoadjuvant chemo.
Because the non-cisplatin options aren't effective enough upfront.
Right. The source suggests the limited benefit of non-cisplatin neoadjuvant chemo doesn't outweigh the risks and potential delays to potentially curative surgery. So cisplatin eligibility is a huge factor in planning treatment for MIBC.
Okay, that makes sense. Let's quickly touch on upper tract urothelial carcinoma cancers in the renal pelvis or ureter. Is the management similar to bladder cancer?
Similarities exist, yes, because it's the same cancer type lining those structures, but there are also unique challenges. The source notes that getting good tissue samples and accurately staging these upper tract tumors endoscopically is often harder than for bladder tumors.
How are low-risk upper tract tumors usually handled?
The source defines low-risk upper tract tumors as solitary, low-grade, small, under 1 centimeter, no invasive signs on imaging. These can often be managed with kidney-sparing approaches, like using a scope and laser to ablate or burn off the tumor from inside the ureter.
Trying to save the kidney.
Exactly, or sometimes surgically removing just the affected segment of the ureter and reconnecting the ends.
What about high-risk upper tract tumors? Bigger, higher-grade, invasive ones?
For those, the preferred surgery is nephrorectomy. That means removing the entire kidney and the entire ureter on that side, all the way down to include a little cuff of the bladder where the ureter enters. It's the upper tract equivalent of a radical cystectomy.
Okay, removing the whole system on that side. Are there times they might try to spare the kidney even with higher risk disease?
Yes, the source mentions situations where nephron sparing might be considered, especially if the patient already has poor kidney function and losing a whole kidney would be devastating, potentially requiring dialysis. Segmental ureterectomy might be an option in very select cases.
Okay.
And specifically for CIS, carcinoma in situ, in the upper tract, sometimes they can instill BCG therapy through a tube placed directly into the kidney, a nephrostomy tube, to try and treat the CIS while saving the kidney.
And does systemic chemo play a role in upper tract disease like it does in MIBC?
Yes, it does. Neoadjuvant cisplatin-based chemo given before surgery has been linked to about a 14% rate of pathologic complete response, meaning no cancer found at surgery in upper tract patients.
And after surgery? Adjuvant.
Yes. For patients undergoing nephrorectomy for high-risk disease, giving adjuvant platinum-based chemo, either cisplatin or carboplatin, after surgery was shown in a randomized trial to cut the risk of recurrence by 55% compared to surgery alone.
Wow, 55% reduction. That's significant.
Very significant. So the source states that based on this evidence, using perioperative chemotherapy either before or after surgery is now recommended for high-risk upper tract urothelial carcinoma patients in national guidelines. Another example of research changing practice.
Okay. Finally, let's tackle the most advanced stage, metastatic disease. Stage 4. When the cancer has spread beyond the pelvis with that very tough 5% 5-year survival we mentioned, what's the standard approach here?
For patients with metastatic urothelial carcinoma, whether it started in the bladder, renal pelvis, ureter, or urethra, the established standard of care is systemic therapy, treatment that goes throughout the body.
Historically, what was the main chemotherapy for metastatic disease?
The source points to a landmark trial that established MVAC as the standard. That's a combination of methotrexate, vinblastine, doxorubicin, adriamycin, and cisplatin. That trial showed MVAC boosted median overall survival from about 8 months, with just cisplatin alone up to 12.5 months.
So, combination chemo was clearly better. What's the current standard chemo and why did it change?
Well, a later big trial directly compared MVAC to a different combo, cisplatin and gemcitabine, or CG. This trial found that CG gave similar overall survival results to MVAC, but it had a better side effect profile. It was generally easier for patients to tolerate.
Similar effectiveness, but less toxic.
Exactly. So, since around 2000, the source says either MVAC or CG is considered a standard first-line treatment for metastatic patients who are fit enough and have good enough kidney function to handle cisplatin. CG is often preferred now because it's generally better tolerated.
Now, even with effective chemo like CG or MVAC, we know the overall stage IV prognosis is poor. Are any patients with metastatic disease cured with chemo alone?
The source says cure is possible, but only for a very small, specific subset. Maybe 15–20% of patients who have metastatic disease confined only to lymph nodes and who are otherwise in good health, good functional status.
But how common is that specific scenario?
Unfortunately, the source adds that only about 5% of all patients presenting with metastatic disease actually fit that profile of having only lymph node mets and good functional status.
So cure with chemo is possible for a tiny fraction, but not the reality for most with stage 4. And we know about half of metastatic patients can't get cisplatin due to kidney problems or frailty. What are the options for them?
Historically, carboplatin-based chemo regimens have been used as the alternative for cisplatin-ineligible patients. But the source notes these regimens consistently lead to lower median overall survival rates compared to cisplatin combos maybe around 9.3 months. So they're an option, but less effective.
Right. And this is where those newer therapies we touched on earlier, the immunotherapies, the targeted agents become really crucial, isn't it? Especially for patients who can't get cisplatin or whose cancer progresses after initial chemo.
Absolutely. This is where the landscape has really changed. The source highlights that agents targeting the immune checkpoint pathways, the PD-1 and PD-L1 inhibitors, have become additional standard options. These are the immunotherapies.
What are some of the key immunotherapy drugs mentioned?
Examples listed include atezolizumab, pembrolizumab, nivolumab, and avelumab.
And how are they used? In what settings?
They have several roles now. Atezolizumab and pembrolizumab can be used as initial first-line therapy for patients who are ineligible for any platinum chemo, cisplatin or carbo.
Okay.
Avelumab is used as first-line maintenance therapy, meaning for patients whose cancer hasn't gotten worse after initial platinum chemo, avelumab can be given afterwards to try and prolong the response.
Ah, maintenance.
And then pembrolizumab, nivolumab, and avelumab are also standard options in the second-line setting for patients whose cancer has progressed after getting platinum-based chemo.
Now, the source mentioned these immunotherapies often have lower response rates than chemo, maybe 10–30%. Why were they approved if fewer tumors shrink initially?
That's a really important point. The source explains it well. While the initial shrinkage rate might be lower, these drugs got approved mainly because they have better safety profiles overall compared to chemo, and critically, because the responses, when they happen, can be incredibly durable. They can last a very long time in some patients.
So fewer people respond, but for those who do, the benefit can be much longer lasting.
Exactly. Even if it's just stable disease or a partial response, it might last much longer than a typical chemo response.
And how do they work again, briefly?
Fundamentally different from chemo. They don't directly kill cancer cells. They block signals, like PD-1 or PD-L1, that cancer cells use to hide from the immune system. By blocking these breaks, the inhibitors allow the patient's own T cells to hopefully recognize and attack the cancer.
And because they work via the immune system, the side effects are different, too.
Totally different. They cause immune-related side effects when the revved-up immune system mistakenly attacks normal tissues. The source stresses these are rare, but can be severe.
Like what kind of things?
Inflammation in various organs, colitis in the colon, pneumonitis in the lungs, hepatitis in the liver, nephritis in the kidneys, myocarditis in the heart, also skin rashes, thyroid problems, neurological issues like Guillain-Barré, blood problems like ITP, adrenal insufficiency, a whole range of potential immune reactions.
So definitely not without risks, just different risks than chemo. Needs careful management. Are there other types of targeted therapies mentioned for metastatic disease beyond immunotherapy?
Yes, for
If
patients whose cancer progresses after platinum chemo, the source introduces specific targeted drugs. One is erdafitinib.
Erdafitinib, what does that target?
It's an oral drug, a tyrosine kinase inhibitor that specifically targets the FGFR pathway. It's used for patients whose tumors have specific activating mutations or fusions in the FGFR2 or FGFR3 genes.
Ah, FGFR again. We saw that in the low-grade NMIBC.
Exactly, but these alterations can also be present in invasive and metastatic tumors. For patients with these specific FGFR changes, the source says erdafitinib achieved a response rate of about 32%, lasting a median of around 5.4 months.
So a targeted pill, but only for patients with that specific molecular marker. Is there another targeted agent discussed?
Yes, the source also talks about enfortumab vedotin. This one's different. It's an antibody-drug conjugate.
Antibody-drug conjugate. How does that work?
It's like a guided missile. An antibody targets a protein called Nectin-4, which is very common on urothelial cancer cells. Attacks to the antibody is a potent chemotherapy drug, so the antibody delivers the chemo directly to the cancer cells expressing Nectin-4.
And when is enfortumab vedotin used?
It's become a standard option for patients who have already progressed after getting both platinum-based chemo and PD-1, PD-L1 immunotherapy.
So a later line option, does it also require a specific mutation, like erdafitinib?
No, and that's a key difference. The source notes enfortumab vedotin is used independent of tumor mutation status. It targets Nectin-4 expression, which is just generally common on these cancer cells.
And how well does it work in that setting, after chemo and immunotherapy have failed?
Response rates are notably higher than what you typically see with other options in that heavily pretreated group, around 44%, according to the source. And it specifically highlights that responses were seen even in patients with tough-to-treat liver metastases. The median duration of response was about 7.6 months.
That's impressive for patients who've run out of standard options. Provides a really valuable next step.
It certainly does. And the source just briefly concludes the treatment section by saying, additional novel therapies are still under investigation, reflecting that ongoing research effort.
It's just fascinating to see that whole journey, isn't it? From discovering things like FGFR3 mutations or those TCGA subtypes, directly leading to the development and use of drugs like erdafitinib or immunotherapies that work with the body's own biology. The treatment toolbox is clearly way bigger and more complex than it was just, say, 10 years ago.
It's a direct result of that accelerated understanding of the molecular biology we talked about right at the beginning. Treatment is definitely getting more sophisticated, trying to leverage those insights.
Well, we have covered a ton of ground in this deep dive, all guided by Chapter 86 of our source text. We started with the big picture bladder and urinary tract cancer being, the sixth most common cancer in the U.S., second most common GU cancer, and really highlighted that rapid evolution driven by molecular discoveries.
Then we went into the clinical epidemiology, demographics, genetics, environmental factors, and really drilled down on that overwhelming preventable link to tobacco smoking.
Then we moved into how it presents, stressing that key symptom of painless hematuria, and walked through the diagnostic workup cytology, cystoscopy, imaging, and the crucial role of that initial endoscopic resection for diagnosis and staging.
We explored the histology, noting that while urothelial carcinoma is king, those variant features can really matter for prognosis. Then we did a deep dive into the molecular biology, the biphasic nature, the specific genes like FGFR3, TP53, RB1 driving different behaviors, the Lynch syndrome link, and those huge findings from TCGA, especially molecular subtypes.
And we saw how stage T and M directly correlates with prognosis, emphasizing that dramatic drop in survival once it hits the muscle or spreads regionally or distantly.
Exactly. And finally, we unpack that complex treatment landscape, the strategies for NMIBC with TURBT and intravesical therapy, including BCG's role and limitations, the aggressive treatment needed for MIBC bladder sparing versus radical cystectomy and diversion, the specifics of upper tract cancer, and the evolving standard for metastatic disease moving beyond just chemo to include immunotherapy and targeted agents like erdafitinib and enfortumab vedotin.
Our goal through all this was really to take you through this complex topic with the kind of detail and insight professionals get from a source like Chapter 86. Hopefully this deep dive provided some real aha moments, give you clear, structured understanding, and didn't just feel like, a huge data dump.
Hopefully it cut through some of that noise we talked about at the start.
I definitely feel like we got past the surface noise and into the really critical details. And as we wrap up, thinking about everything we've covered, the incredible molecular complexity from TCGA, the new targeted drugs, immunotherapy, it still kind of brings us back to a challenge the source highlights, maybe implicitly.
Yeah, especially around those molecular subtypes and where we are with biomarkers right now.
Exactly. We know bladder cancer isn't just one thing at the molecular level. We have these amazing new drugs targeting specific pathways or using the immune system. But the source describes finding these subtypes and targets, and then often describes treatments still being applied based more on stage or platinum eligibility. We're still figuring out how to perfectly use all that molecular knowledge to precisely predict which patient will respond best to which specific therapy before we even start treatment.
Yeah, that raises a really important question, doesn't it? What is this ongoing challenge? Matching treatment to patient perfectly, despite knowing so much molecular detail and having new drugs. What does it tell us about just how complex cancer is and maybe the future path for truly personalized medicine?
It really suggests that the interplay between the tumor's own biology, the patient's immune system, how they interact with the therapy, it's incredibly intricate. It's clearly not a simple one mutation equals one drug situation yet. Personalized medicine is definitely here, but that truly precise predictive treatment selection, that's still a major frontier we're working on. Something for you to definitely mull over as you think about everything we've discussed today.
Indeed. That journey from biological discovery to perfectly optimized clinical practice. Sure. It's a continuous one, always evolving.
A fascinating and incredibly vital area of research and care, no doubt.